In this episode, we will continue our discussion of travel medicine by focusing on some high-yield cases related to non-diarrheal GI symptoms in traveler, mainly fever and abdominal pain with or without jaundice, jaundice itself, hepatosplenomegaly or hepatomegaly alone. Each one of these have their own specific differential diagnosis. So the first case is a patient with fever, abdominal pain, and a salmon-colored macule on the trunk. What striking sign you can expect in this patient? The relative bradycardia for the fever. This is a characteristic finding in Salmonella typhi and paratyphi causing enteric fever. Now, if this patient is otherwise stable, what is the course of management? Even though antibiotic sensitivity and resistance pattern based on the culture results are recommended mainly for the areas with availability of such tests, if the patient has fever, abdominal pain, and is from the endemic regions from which he or she is traveling, we can start the antibiotics. Remember, ceftriaxone or a fluoroquinolone is the choice of antibiotic for enteric fever. Now, if the same above patient now has complicated symptoms indicating peritoneal signs or septicemia. First question is, what's the mechanism of the septicemia in this patient? The answer is intestinal obstruction. And the next question is how the management of this patient now differs. We should add corticosteroids such as dexamethasone for the management of complicated enteric fever. Now let's discuss some more cases with focus on hepatobiliary tree and reticuloendothelial system involvement in traveler, beginning with a patient with fever, right upper quadrant pain, with or without jaundice. What are the differential diagnoses in this patient? Differentials include liver abscess, liver fluke, and echinococcosis. So let's discuss some cases for liver abscess. First, you have a patient with fever, right upper quadrant pain, nausea, vomiting, malaise, and weight loss. What is the next step in the assessment of this patient? Initial diagnosis is made by imaging, especially ultrasound or contrast CT, but confirmatory diagnostic and further workup includes percutaneous needle aspiration and culture. Usually these two are performed together, that is, PCNA is ultrasound or CT guided. What are the two important decision point questions regarding management of a patient with liver abscess? One is differentiating between amoebic versus pyogenic liver abscess given the different workups that each one require beyond the initial steps that we mentioned. And the second important thing is to know surgical indications in management of liver abscess. Pay close attention to these two cases. We have a patient with fever, right upper quadrant pain, nausea, vomiting, weight loss, and malaise. And his medical history is significant with recent travel or bloody stool. In addition to initial workup that we mentioned, what further diagnostic tests are required in this patient? Given the fact that this patient has history of dysentery and travel, this is amoebic liver abscess, and management requires serologic tests and assessment of stool for ova and parasite if not already done. Next is a patient again with the triad of liver abscess, that is fever, right upper quadrant pain, and malaise, and the patient has history of diabetes. Question 1. What physical exam help rule out important differential diagnosis in this patient? Presence or absence of Murphy sign, as cholecystitis is an important differential diagnosis, especially for pyogenic liver abscess. Why is it so? Because both conditions can have same presentation, and the risk factor for both conditions could be gallstone disease. Continuing our case, ultrasound shows a fluid-filled hypoechoic lesion in the liver. What laboratory abnormalities you expect in this patient? Always remember, in patients with pyogenic liver abscess, we have hyperbilirubinemia and leukocytosis with left shift, and these together with risk factors help differentiate it from amoebic liver abscess in which bilirubin is usually normal. What's the initial management for liver abscess? Percutaneous needle aspiration. What factor determines if catheter placement is also needed? If the size of abscess is larger than 5 centimeters. What's the next step if first attempt at drainage fails? A second attempt for drainage before surgical drainage should be performed. What are the indications for surgical drainage of liver abscess? Usually performed either with open surgery or laparoscopically. If the abscess fails 2 needle aspirations, if there are multiple or loculated liver abscesses, if they are deeply seated, or if there is ruptured abscess, and of course if patient has any underlying disease such as choledocholithiasis or appendicitis that requires surgery. Remember, if a patient has general contraindications to surgery, you should first remove those contraindications. These indicate coagulopathy, thrombocytopenia, or sepsis. Okay, moving to our next case of travel medicine with in a patient with fever, right upper quadrant pain, possible jaundice, but this time seen in a patient resided in a sheep rearing or sheep raising areas. Always remember 2 important differential diagnoses of these liver pathologies: liver fluke and echinococcosis. How do we differentiate these 2? In a patient with liver fluke, we expect a history of aquatic plants consumption or freshwater fish consumption, as well as eosinophilia. Otherwise, and especially cases with patients residing in high latitude sheep raising areas, we suspect echinococcosis. So first case is a patient with fever, right upper quadrant pain in sheep rearing areas with history of aquatic plants consumption such as watercress, and initial labs show eosinophilia. What is the management of this patient? This patient has the symptoms and signs of liver fluke. The next step for confirming the diagnosis is stool for ova and parasite that shows elliptoid or ovoid eggs, and management is triclabendazole. Again, liver fluke means triclabendazole. Now we have another patient with fever and right upper quadrant pain who reports contact with canine in sheep raising high latitude areas. What is the management of this patient? Given the high likelihood of echinococcosis, we need to order diagnostic imaging and serology. What is treatment? Albendazole and surgery. True or false? An alternative to surgery for echinococcosis is aspiration. That's false given the risk of anaphylaxis. Aspiration should be avoided. Treatment is albendazole with surgery. Next, I will briefly discuss some differential diagnosis in other non-diarrheal GI symptoms in travelers, including those with jaundice, hepatosplenomegaly, or hepatomegaly only. Thanks.